Hey everyone, it's Denise Brown from the Caregiving Years Training Academy. Thanks everyone for being here. This is our fourth annual Big Ideas event. Thanks to those who are joining us live and thanks to those who are watching our archive. We're going to present two ideas to you today, and then we're going to open up for a conversation about the ideas. We'd love to hear what you think. So our first idea is going to be presented by my friend and colleague, Tim Peck. So Tim is a serial entrepreneur and Harvard-trained emergency medicine physician. Most recently, Tim teamed up with a Fortune 500 insurer to create CareScout, which delivers products and services that will change the way we navigate aging. Tim is currently living on his 40-acre farm outside Louisville with his wife and son, writing his first book on redesigning the healthcare system to be more desirable to the patients and families who must navigate it. So welcome, Tim. Tell us about your idea.
Thank you, Denise. I appreciate it. And thank you for everyone attending today. I'm Tim Peck. I'm a physician, a serial health tech entrepreneur, an advocate, and a designer, all in the aging space. And so as a profession, I get to think about and act on designing and redesigning systems. Fundamental to my work is the belief that the healthcare system is not broken, as so many say, but instead is working exactly as designed. It was just designed very poorly. We've all had our own experiences with the US healthcare system, and these experiences have often been frustrating, disappointing, or sometimes even harmful. And what I'd like to ask you to do, step back from those experiences today, just for a moment, and ask yourself, while looking at those experiences, why they're happening to you and your loved ones. Why do you wait so long on that crinkly white paper for your doctor to see you? Why don't we get a call back when we have a question for our physicians? And why aren't we healthy even though we take all those medications? And why do so many of us die alone and in an ICU or hospital rather than surrounded by our family in our own homes? So human-centered design must have three things to be true to be good design. It has to work. It has to do the thing it was designed to do in an efficient way. The second thing for human-centered design is that it must exist on its own. So after the designer creates it and pushes it into the world, can it support itself when the designer can no longer influence it? And then third, it needs to be something that people want to use. Do they like it? Do they love it? And so the healthcare system is way overbalanced to the first two legs of that stool. It's balanced to support institutions and businesses' ability to exist and financially support themselves in their ability to work and run efficiently on the resources at their disposal. Both of those things are important. If our providers can't support themselves and do their jobs efficiently, we wouldn't have a system at all. But current design of the healthcare system rarely values and invests just as equally in the third leg of the stool, your experience. That's because back in the 60s, we as a society did something pretty incredible. We came together and decided that our citizens should be entitled to healthcare if they were vulnerable. And so we made Medicare for the aging and disabled, and we made Medicaid for the disadvantaged and poverty-stricken. It's an incredible and noble cause. But unfortunately, we designed it in such a way that whenever care was delivered by the system, those delivering it would be paid for their time, not their value. So no matter how bad or good the care was, it would be paid for at the same amount. Even if you, the patient, weren't healed, were inconvenienced, had your feelings and emotions dismissed, or even if you were hurt. The result has been a system in which user experience is a distant third to efficiency and financial viability. That's faulty design, and the everyday consequences are clear because of this design. You don't have transparency on which provider has a better user experience than the other. You're choosing blind. Because of this design, the most valuable clinicians in our system Our nurses, our social workers, our case managers, they're treated as cost centers rather than value drivers. And because of this, the homeless, the disenfranchised, the chronically ill, the superutilizers, those who need the most time and attention to achieve health, are seen as a nuisance, clogging up our emergency departments. And those receiving palliative or long-term care at home are seen as time-consuming, margin-reducing, rather than the valuable, inspiring cornerstones who can show us how to live our best lives. Being sick in this country, especially while in the last third of life, is a dehumanizing process that is exorbitantly expensive, a combination that would quickly drive any other business out of business. Because the Medicare system was designed so poorly back in the 60s, the programs rapidly headed toward insolvency. In only a few short years, Medicaid will have about a 10% budget shortfall. And we'll either need to raise taxes by $80 billion a year, or cut back on care by $80 billion a year. This is an impending crisis. I'm a systems designer, and what we do is we look at who has leverage in moments of crisis to predict what the most likely outcome will be. So right now, those with the biggest voices are the insurers, the pharma companies, the hospital systems, the providers in some ways. And as long as there's enough money to pay them, they'll continue to have the biggest voices. But this impending crisis that we've spoken about gives the sick, the aging, the caretakers an incredible amount of power to demand a more desirable system in the form of economic leverage. I think most of us here can agree that a good care in the home is more desirable than institutional care in most cases, and it's less expensive. We can use those facts to mobilize a message and a movement to our politicians that shifting care into the home can serve to help save the system as a whole. But recall, the current design doesn't incentivize that to happen. I've spoken to over 200 politicians, congresspeople, senators, and what I've learned is simple. Because of the way the system is designed, whatever the new design is, will need to be less expensive than the current design. Dignified living with the assistance of one's caregiver inside the home, rather than in institutions, already does this. So I ask you, how might we work together to reframe aging and being sick as a movement of economic empowerment? What might happen if we spread the message and say to our politicians, we'd like to cost less, please, so that we can get more? We are in a historically divided time right now. We all know that. But history has taught us that in moments of crisis, change is not only necessary, but typical. The impending Medicare insolvency within this decade represents an opportunity we can't waste. So how do we redesign the system to make it more desirable for the patient? Fortunately, we have a very recent case study to point to and to illustrate how these changes are made. One that's quite personal to me, the adoption curve of telemedicine during the COVID epidemic. Telemedicine was built to disrupt the principle that it's somehow better to bring people to the care rather than care to the people. Telemedicine allows for patients to be reached where they are, rather than requiring them to be transported to the big box hospitals where it's dirty, dangerous, inconvenient, infectious, definitely delirium inducing, costly, uncomfortable, and often very harmful, if not sometimes deadly. And to do so at a markedly reduced cost to the system that we already have learned currently incentivizes wasteful prices to serve and support its own interests. When COVID hit, the healthcare system was in danger of crumbling. Provider systems were losing $1 billion a day because patients were finally able to act like typical consumers and vote with their feet. US patients decided to stay home en masse, not call ambulances, and chance being sick at home rather than go to the hospital where they would be exposed to a deadly and at that time untreatable disease. The federal government made some emergency waivers and passed some bills, and in a matter of a single week in March of 2020, Medicare and health insurers had to pay health systems and providers for doing telemedicine visits. This served as an incentive for providers to create and deploy telehealth, and in a matter of weeks, every major hospital system in the country was using telemedicine. Caregivers and patients began to ask themselves things like, Why before the pandemic did I have to take the day off from work and bring my mother to her 5-minute diabetes appointment when I could have just used telemedicine at home? The answer is quite clear. The system is designed for its own financial viability and efficiency first, and you and your mother's diabetes second. But it also unveiled something magical, that patients, their families, and their advocates do, in fact, have a say. That when there's a crisis, voice can be given to the voiceless and power can be exercised with effect. Telemedicine was implemented because patients said they wanted it. Although this change happened rapidly in that 1 week in March of 2020, the work had been done mostly in the years before that. In the decade leading up to the pandemic, there were tomes of evidence and incredible case studies of telemedicine's effectiveness. I was part of the movement who worked with Congress to educate them about the benefits of telemedicine and systems design. Bills were introduced and passed that allowed for specific case studies to be paid for by Medicare, like telestroke and telemedicine for home dialysis, and using telemedicine to reduce unnecessary trips to the hospital from nursing homes. So when COVID hit, politicians quickly passed the laws needed to make real and lasting change because the blueprint was already in place. Medicare insolvency is an analogous crisis that we cannot let go to waste, that we can plan for as well, because we know that the crisis will happen. When we can no longer pay for Medicare as a country, either taxes will be raised or the program will face cuts. Neither of those options will be politically popular, and politicians will be desperately seeking another option in order to get votes and save their jobs. And so by educating politicians on the blueprint now, when the time comes, they can pass the laws needed to incentivize the healthcare system to be better for the patient and in the process cost less. Why would they not use this blueprint? The history of crisis management shows that they will. The next step is to start to lay out this blueprint and create a movement of change. I'll be publishing a book on the subject next year. The thesis is quite simple. Similar to other markets like retail and entertainment, we'll stop rewarding providers for just when they deliver services irrelevant of experience, and instead reward providers for when they deliver user experiences that patients love. Unlike retail or entertainment, however, we'll also reward providers for meeting person-centered care metrics to keep quality high. This will include things like paying hospitals more when their nursing is better, paying emergency departments more for sending certain patients home rather than admitting them to the hospital, forgiving the school debts of healthcare providers who deliver great user experiences or create innovative care solutions, rewarding electronic medical record companies for ease of use and interoperability, giving bonus payments to pharma companies who allow their drugs to be generic sooner than required, and paying not only for family caregivers' time, but also for their training, as well as the services that we know improve their ability to give care, like transportation, meal prep, house repairs, and companionship to thwart loneliness and isolation. You are the way these changes are made. By reframing aging and caretaking as a movement of economic empowerment, laying out the blueprint, and making sure your voice is heard when the movement and the moment comes for action. The way to start to make this happen is through conversation. So please reach out to me to talk about what you're working on or what you're struggling with. I truly want to talk to you about your experiences and your ideas for change. Thank you.
Okay, thanks, Tim. And I'm going to post the link to Tim's LinkedIn profile before we close today so you can connect with him. Okay, so I'm going to talk about something specific within the healthcare system, and that's the emergency room experience. And if you've had a recent emergency room experience, I'd love for you to share a little bit about that in the chat room. So if you haven't, there's a crisis in emergency rooms, and we are having a hard time effectively managing the patients who are going to emergency rooms. And a recent survey said that 1 in 4 doctors said patients waited more than 2 weeks to be admitted to their hospital or transferred to another place. So I cared for my parents for many years, for my dad, almost 20 years. And my dad, who died this past July when he was 91, almost 92, really believed up until the day before he died that he was 50. So he lived a life of being a 50-year-old man in a 91-year-old body. So that meant he took terrible, horrific falls. And one fall 2 years ago landed him in the emergency room. And you can see that he's all bandaged up. You can't see what happened to his forearm. He had a terrible skin tear. This is actually almost 24 hours into his visit in the emergency room, and I'm sitting across from him. And because he was sleeping, I was looking at, what does this cubby look like? And I'm using the term cubby informally. There's probably a better term to use for the space we occupy in the emergency room, but for our conversation today, I'm going to call it a cubby. And I started looking around, and then I thought, I have to take pictures of this. And after my dad got up, I took a picture of what it looked like behind him, and I took a picture of one of the walls. In June of this year, my dad went to the emergency room again because he fell. And I spent a lot of time alone in one of the cubbies because my dad was waiting to have x-rays to see if there was a fracture. And I wish I would have thought to take pictures of that emergency room, but I didn't. But it's very similar to what it looks like here. All the walls really are either bare or full of equipment or supplies. I thought there's got to be a better experience in the emergency room, especially because think about all the individuals the emergency room cares for. It's not just patients, it's also family caregivers, but it's also staff. So I started to think about what could we do in emergency rooms so that they are much more effective in how they take care of us. I thought about, what if there was a wall of resources in each cubby? And it's just sharing information that's helpful for a family caregiver. If you've been in an emergency room recently, when you step into the restroom, you'll notice that there are flyers in the restroom in case you are in an unsafe situation. And they give you directions about how to alert staff if you need support. I thought we could do something around supporting family caregivers with information in the cubbies. So what if each cubby had something like a little map? And it's a map to show where a caree goes for x-rays or MRIs, because it's helpful to know where they are even if we're not with them. So when I got to the emergency room on that Sunday night in June after my dad fell, he was living in an independent living community, I was in the cubby for hours waiting for him. And I would ask, where is he? And they would say, he's getting x-rays. But it turned out he really was in the hallway waiting to get an x-ray. And it felt so odd not to know where he was. It increased my anxiety about how he was doing. And I just it would have been helpful just to have a little map about where the x-ray machines are. Where do they go for MRIs? In addition, I had no idea who to reach out to. Now, I appreciate that maybe if you're a staff member in an emergency room, it might not seem like you want to have everybody know who you are, but maybe there's a way to share one point person that a family caregiver can reach out to for help and support. We know that on whiteboards in hospital rooms, there's typically the name of the nurse who's on shift and then the patient care tech. So something like that in the cubby. And then what if there was a flyer that listed caregiving resources so that while the family caregiver is sitting, waiting, or watching a caree sleep, they can actually look for help or connect to support. And I created a flyer that I'll show you in just a minute. The other thing that happens in an emergency room are really traumatic experiences. Our experience leading to the emergency room can be traumatic. And then we see other things happening. For instance, a patient who is admitted because of a car accident or other traumatic experience. So what do we do when we see that trauma? So I think it would be helpful for us to understand, what do we do as the witness to this? Where do we go? How do we manage? And I also think it would be helpful to have guidance around if the staff is attending to a patient who is having a critical care episode. What do we do if something happens to our caree, the person receiving our care? So there could be some guidance about how do we manage if there's already a crisis and it looks like our caree is going into crisis. Who do we alert? The other thing that I think it would be helpful is what can we do when we see something traumatic? So giving the staff space, maybe closing our curtain, and then depending on the hospital system, say a prayer for the patient and the staff. In addition, what if we need to see the chaplain? How do we do that? And how do we do that so that it's not bothering the staff again? I also think it would be helpful if we had guidance around how to get extra blankets. My parents were always cold in the emergency room. And I would ask, and it seemed like it was behind this hidden door, but it really wasn't. And I could have gone to get the blankets myself. I just didn't know where they were. And then how do we get to the cafeteria? We know that hospitals are just a maze of corridors and hallways. What's the easiest way to get to the cafeteria? And then if there's some outdoor space we could take advantage of, how do we get there? Some hospitals have really beautiful gardens. How do we get to a garden to sit, meditate, and pray if that's something we feel better doing? Okay, so this is a flyer that I created that has just simple suggestions about how to get more help. And I included a QR code because maybe the family caregiver says, oh gosh, I'd like to look into these resources, but I think I'm a little stressed out and distracted, but I want to save this as a resource. So this flyer could be customized based on the hospital system, could be customized to include special programs that the hospital offers or special programs within the community that the hospital is affiliated with. So it doesn't have to look exactly like this, but I think it's a nice guide. And then if there is a wall of resources, this is just one flyer that's a part of it. And the wall could include this flyer, the maps, and then guidance about how to manage what you see in the emergency room, which can sometimes freak you out. So how do we manage? And I think this wall of resources can be really helpful for the staff too, because we're going to the nurse's station on a regular basis to ask, what do I do? Where do I go? How do I get? And if there's information in the cubbies, then we can save the staff some time. So the resources that I picked to put on this flyer include how to search for help, how to get support, information about training videos, how to search for information on Medicare, and then guides that can help with transitions between a hospital discharge and a return to home, for instance, or information about a disease process. Okay, so I'm going to post these links before we go to, because I'd love to know about your emergency room experience. What was it like? We're going to start an advocacy campaign in November, which is National Family Caregivers Month, to help emergency rooms add these wall of resources, which are low-cost solutions to their emergency room. And if you'd like to help us spread the word, you can join our special group on our community, Caring Our Way, called a Caring Advocacy and Awareness Volunteers Group. Interestingly enough, we're also going to start an awareness campaign in November around paying family caregivers through Medicare and hospital at home programs and hospice programs. So kind of aligning with where Tim was going, this idea that if we want to provide care at home, we're asking family caregivers to do more. And it's important that family caregivers are reimbursed because family caregivers are the 24/7 provider within the system. And yet they are the only provider who does not receive reimbursement. And we need to change that. And we need to change that as the shift is coming more and more to care at home. If we're going to ask family caregivers to do more, we need to be able to reimburse them. Okay, so that is my idea. It's the wall of resources. Okay, so we're going to open it up for a conversation. So here's how we're going to do it. You are welcome to share insights, reactions, and questions in the chat room. You are also welcome to unmute yourself. And I would ask if you unmute yourself to go right to the bottom line. Ask us your question or share a criticism or share a endorsement, but get right to the bottom line so we can keep the conversation going. Okay, so Tim, what did you think?
I think what you're hitting on is that the world outside of the emergency department, when treating someone in the emergency department, is probably more important than what's going on in that ED. And so as an emergency physician, if only I can connect to all the resources that are not in front of me, I do a much better job. And so I think you're creating a portal to that. And if you start to iterate off of your idea and where does technology come into play, and creating portals into other spaces other than where you are in that physical ED, the idea just grows to be something interconnected that can, markedly increase the amount of resources you have to help people.
And I think it's this idea that we can look to simple solutions that can have a profound impact. We don't have to spend and invest a ton of money in really connecting family caregivers to support and help. We can think about it as there's room on the wall, so why not use the wall? I also think there's other things we can do in the emergency room to make it a more pleasant experience, but honestly, that costs money. So I really wanted to focus on what's the low or no cost solution we can look to in an emergency room. Tim, as a physician, I'm just curious, what were the greatest challenges you encountered in the emergency room?
And the biggest for me that made it so that I said it's time to leave traditional medicine and start to become an entrepreneur and tackle some of these problems was for those who are very sick, especially the aging, who needed our care the most, were the patients that we put in the hallways that you just showed example of.
Yeah.
And it was so easy to put a patient from a nursing home or from home who was 80 plus, who came in and was invariably delirious from the lights and sirens, from the fever, from whatever it might be, and usually quiet delirium, right? Internally preoccupied, not speaking. So easy to put that person in the hallway and treat instead the 30-year-old with a broken leg who's screaming. And who needs actually more care, more attention? The one we put in the hallway. And that injustice was very hard to be the end user of. And I realize it's not a people problem, but a systems problem. And so, the fact that a system exists that all of us, many of us on this phone, are the end user of, and even if we don't agree with it, we need to do our best to follow out the best care we possibly can, is what really got under my skin enough to say, let's try to make.
And feel free to post questions in the chat room, or if you'd like to raise your hand and unmute, that would be great as well. But something that I really started thinking about was system navigation, which I had heard about for years. And then I decided to count systems that we navigate and manage and advocate within. And when I first came up with the list, I probably had 5 or 6, and I would include this training in our certified caregiving consultant training, so our caregiving coaches. And when I would pull up the slide and say, here are the systems we navigate, I would ask, what did I miss? And then it was always so eye-opening to hear what I missed. And the first time I asked that question, a training program participant said, nervous system. And your insight about who's in the hallway also impacts our nervous system. And it's not just the nervous system of the patient, of the family caregiver, but also the staff. The staff feels it. Why are we putting patients in the hallway? Well, we haven't set up a system within the system that manages the individual needs of those who are being admitted, those who are showing up at the emergency room. So when I finally decided to sit down and really count, I first came up with 10, and then it was 12, and then it was 15, and then it was 17. And when I got to 17, I said, that's it. I'm not going to keep counting. That's enough. And if we think about the 17 different systems, the connector between all those systems is the family caregiver. There's no way a hospital can intersect with all of those systems because it's not set up to. So the other one that I think about as a hospital experience is discharge day. So on discharge day, a discharge planner will say, this is the day, but no one has ever asked me, as someone who has a small business, when's a good time for us to plan this discharge? We know that you're juggling a lot. What would be the best time for you? It's never about that. It's always about, when do we get the final order from the physician? When have we gotten all the medical equipment confirmed that it's been delivered? When has everything aligned? And so as the family caregiver, you are always making yourself available. So you show up early, you wait, you do whatever you can to move the system forward, but it's always the system that decides. And so we get tired of cooperating with what doesn't cooperate back to us. And that's the challenge too. And then it impacts our nervous system. Our carees are nervous on discharge day. We're nervous on discharge day. Perhaps the discharge planner is nervous on discharge day too, because it's a lot to organize. It's a lot to make work. So it's interesting to think about how this family caregiver is interacting in all these systems. And yet the system doesn't necessarily recognize that it's the family caregiver doing all this. Okay, and so we have a great question. Oh, go ahead, Tim, and then I'll.
Yeah, if I may, I love all those concepts, and I think the caregiver is the key to chipping away at how we give better care to these patients, to these people, to the people we love. Part of my point is that whole scenario that you just brought us through is tied to how we pay for it, right? If you have someone in the hospital, they're going to use a DRG code, and they have a UTI, and they're going to get paid for 3.1 days. And once it becomes 3.2 days, you become a cost center. And so you need to move out faster. And so, there have been some incentives put in place or penalties around readmission penalties, et cetera. But at the end of the day, those are not really more than what you'll make by getting that patient out sooner. So until you change that, it's going to be hard to fundamentally change everything. But if we have that as a constraint and have to work within that payment system, that's why I think we're friends, is the caregiver is the point that you need to use and enable to be able to solve all these things. So,
okay, and here's our question in the chat room. What do we consider the biggest obstacles to improving the aging experience for the future?
I just gave a piece of my answer, right? Like it always comes back to the way that we're paying for this, and the fact that we can't make change right now when there's no crisis. So the fact that we're going to have this Medicare insolvency crisis gives us a moment to say, how do we make the change in terms of payments? But I think a lot of the problems with aging, or the attention that we give to the aging, will be changing quite rapidly as people age even more and our demographics in the US change and start to balloon into needing more and more attention to the larger population of 65 plus and 80 plus people that we're going to have. And we talk about that as a problem. It's going to cost too much. It's going to be an overrun of our systems and our nurses. But what if we flip that script and people here say, how do we take advantage of that reality that there's going to be so much attention put onto this aging population? How do we use that to say to other industries, even outside healthcare, retail, entertainment, hospitality, to say, okay, there's this huge population. How are we going to take care of them? How are we going to give services to them as a community of people, not just within healthcare, but in terms of all the markets that are out there? And so, the answer to your question is really getting help outside of healthcare is going to be the biggest challenge, but it's also, I think, just an enormous opportunity.
And Kathy is sharing in the chat room that it's from her perspective, one of the biggest obstacles is the staffing shortage. And we know that that directly impacts every piece of the system. And I just read yesterday about how many individuals interested in pursuing a nursing career cannot be admitted to a school because there isn't enough instructors and mentors. So there's a staffing shortage from the very beginning of the career, all the way through wherever they go. We do have one other question. Okay, so how might long-term care health insurance be impacted by the possibility of the dilemma that has been presented today? And there's a follow-up around one of our long-term care insurance providers thinking about raising its rates. And I assume that the questioner is talking about premium rates. So what if something that we consider to be an option, like long-term care insurance, no longer becomes affordable for us because of the cost of premiums, because of the cost of care?
So I just want to say explicitly, I've had, I'm a serial entrepreneur. I've built a number of companies here. I recently worked with a long-term care insurer to create Care Scout, and I no longer am employed by them. Kind of finished my block of time there and moving on to the next thing, writing this book, which again, I would love to open up for conversation so I can put your voices in there. So that said, I'm not representing that company any longer. So, but I do know a lot about the long-term care insurance space because of that. And it is not affordable right now. And many people are not even, most sales of long-term care insurance aren't really even happening right now. There's not new plans being sold en masse, at least. And so it's not really a place that we can look to for insurance and guidance right now, unless there's huge innovative ways of changing it. And I think one of the ways of innovative and changing it is going to be what was talked about before, is enabling caregivers to be insured as well. So ensuring caregivers loss of time from work, for example. Right? So because you need to be able to free that person up to give that 24-hour care that Denise talked about. And so I think new insurance products that come are going to be much more focused on the caregiver than the person themselves, the patient themselves.
Okay, and Tom has a comment in the chat room related to obstacles. And so he's sharing that he thinks it's recruitment of caregivers, reimbursement of caregivers, lack of planning earlier in life before you get old, and over-indexing on clinical interventions and not holistic interventions that center the human and their needs. I would also say we are in a crisis around chronic illness for a younger population. And I think we have to look at, I don't know how to say this in the right way, but I think you're going to get where I'm going. We have to think about the aging process as starting really early in life, that the decisions that we make, for instance, in our 20s and 30s impact the health we have in our 60s, 70s, and beyond. And we know that obesity is a problem, diabetes, And we also know that perhaps it could be related to the food that we eat. And so how do we make healthy food affordable for everyone so that you don't have to choose an unhealthy option because that's the affordable option? Okay, so I want to mention one other thing. So there was a concern about my flyer idea and infection control issues with flyers in individual rooms. And so maybe the flyers should be posted in more public rooms. And here's the thing, I did kind of think about what are the risks of having these flyers up in the emergency room cubbies? And there already are flyers posted. And I also kind of go back to this idea that there is a flyer in the bathroom if you feel unsafe. So I would say if you can put a flyer in a bathroom, you can put a flyer in a cubby. But again, I'm not an infection control expert. I think there's going to be some challenges anytime there's something new, but I also think that we can work through it in a way that works. Even if it is just the compromise is it's the flyers in the family waiting room. It's the flyers in the coffee area. Okay, let's see.
Hi, this is
Yes.
Erica Green speaking. Hi
Yeah,
everyone.
go for it.
Thanks for the moment. I want to say I'm really excited to hear about the thoughts that have been going on in this conversation about looking outside of the healthcare system for supporting this aging population. Personal level, I'm essentially elbows deep in caring for two aging parents at home and trying to keep them at home. So a lot of my time has been spent looking at simple things like, so we're gonna have a team of therapists, home health aides, and housekeepers coming in to help them with their activities of daily living. And how do I maintain security, for instance, with all those folks coming in and out? So I've been looking up digital locks, for instance. What's the best sort of digital lock to have on their home that I can keep an eye on what's going on, letting the right people in and out? And it got me thinking, there's going to be a whole series of supportive tools that go beyond, direct patient care that are going to help us with, things like keeping our aging parents at home. How do we keep their kitchens safe for them while maintaining some level of independence and dignity? So Tim, I'd be curious to continue that conversation, or anyone else that has some thoughts around that.
I love that, and you think about some of the big innovators who are changing themselves into healthcare companies also. Walmart, Dollar General recently hired a chief medical officer. What are they going to do, right? Like what you're saying there, Erica, what if ADT started to consider themselves a health company as well? It's going to be, again, with this ballooning population of aging people, there's a market that's being created that will attract other companies into that market, and they will have to start to consider themselves health companies. And that's how innovation is made, when, fortunately or unfortunately, when people are following a dollar, right? So it's exciting to start thinking about some of those ideas.
And I appreciate your perspective, Erica, around safety in the home when you have a lot of people going into the home. That's a huge concern. Interestingly enough, I had the exact opposite problem with my parents. They lived in a condo where the security system was just like impossible. So we were always trying to get people in the house, in their apartment. So it's interesting to think that it could be either one. But we want to keep them safe, and we are relying on help from others. And we are hiring people who we don't have a relationship with. And we are saying to them, take care of the people who are fragile and frail in my life. And that's a huge leap in terms of trust.
Yep, Denise, you're quite right. That my search stemmed from having to get people in the house, right? I didn't want to give everybody a key, but I needed them to get home, to get inside. I can't be there. So it was a very similar start to the search.
Okay, and we have a question from iPhone. So I don't know what your phone number is, and I only see your hand raised. So you are welcome to unmute yourself and ask your question.
Thanks, Denise. It's Robert Witham. Nice to see you again.
Oh, hi. Good to see you. Yeah.
Hi. Yeah, good
Hi.
to see you. Um, Wanted to just make a comment on the last person that was talking. And I'll see if I can put this link in the comments here. But one thing you may want to consider are companies that are out there that can do kind of free um, visits into your home for like home modifications to keep your loved ones safe. And not that you have to go with a contractor, but there are companies out there that will come and do an evaluation, of your loved one's home and space. Um, to and a lot of times they'll do it for free, right? I mean, they obviously want you to choose their service, but they'll do it for free, just to provide estimates on, and kind of just give you tips on what to think about. So I can send a link in there, Denise, if you're okay with that.
Oh,
Not to
sure.
a specific
Yep.
company. They are a company that basically allows you to just to search by zip code.
And we have another question in the chat room around AI. So what could it look like to have AI supporting the aging community?
For me, the sky's the limit there. I mean, there's so much imagination that needs to go into that. I think the fact that the technology is made, it becomes a responsibility for everybody on this phone and everybody to be able to say, you have a new tool, what are you going to do with that? It gets back to when the internet was created, or when all of a sudden we had all cell phones together, like that all of a sudden started, or those are moments where revolutions were started in how we think about healthcare. This is yet another one. So in terms of specific examples, we can debate what those are going to look like, but I think the greatest examples will be the ones that we haven't even thought of yet. We're so early.
Yeah, I have a colleague who actually developed a life story tool using AI, and he's been testing it with older adults who live in retirement communities and also older adults within a neighborhood, so to speak, who use a senior center. And what happens is you start to tell your story, and then the AI prompts for more information. Tell me more, tell me more. And the prompts are directly related to the story that the older adult has been telling, and then captures the entire story for however long it takes to tell the story. And then the organization will actually create like a Word document out of it. So it's a way to tell your story with prompts. And I think that is a really unique and unusual way of looking at how do we engage with older adults to actually capture their legacy, because their life story is part of their legacy.
Yeah, loneliness and isolation is part of what you're hitting on there. And there's a lot of companies, and LEQ, if anyone's seen that, is a cool one where we've got to play with that recently. That's getting much smarter than it was even a year ago because of the AI platforms that are available to it. There's so many dangers, and fixing people's loneliness and isolation with robots. But at the same time, if we have those fears, we should respect those fears as we move forward, rather than just being afraid and never doing anything about it. It's again, I'm just so excited about this opportunity to come up with new ideas.
Yeah, I like this idea that the fears can actually inspire the true change, the true solution. We don't want the fear to stop the innovation. We just want it to be a part of the conversation, the part of the innovation. I just want to mention something else Sue, go for it. Sue, go for it, and I'll share something after you ask or share your insight.
I always jump in and talk at these meetings. Sorry.
Oh, that's okay.
I'm gonna kind of say a little story here of something that I know that happened in my area here. There is a young man who is developmental disability, stays at home with his parents. Parents work during the day. And this was probably about a year ago. I've tried to reach out to this family and tried to, hey, let me go by and see him, or let me give him respite services, this and that. And I think they're like they don't like to be stereotyped, things like that. But you know, there's safety issues that run into things like this. And like she was talking about, how do you make the home safe? This boy's house, I guess he tried to cook by himself. And this is just a little story. And
Hey, Sue, you know what? We're just about out of time. So I would say go to your bottom line. What would be your question, or what would be your bottom line concern?
his house caught on fire and he didn't know to leave. So these are concerns. These are concerns, and I think families need to be more educated and know what's out there, and things not be so stereotyped like, oh, I have somebody who's hurt or, you know, disabled. What do I do? I think they feel like they're, if you get a free service, that they're asking for something, but really it's there. So how do you educate these families better to let them know this is here, and it doesn't mean you're low income. It doesn't mean anything else. It's just there. Just take it. Please let us help. So that's a thing I think we need to look at.
Yeah, thanks, Sue. And I just want to mention that I did post the evaluation in the chat room for CEUs. If you're not here to get CEUs, we'd still love you to complete the evaluation. It helps us as we plan our future events. And I'm curious, Tim, what do you consider to be stigmas around receiving help and support? And I think that that's actually any age. I saw it a lot with my parents, and I see it with myself too. We have a tendency to say, I just want to value my independence and keep living the way I'm living. I don't want to be looked at like I need help.
I think one of the very interesting stigmas that is changing, or is going to undergo a rapid change right now, is the fact that we look at people with chronic illnesses often as something that's wrong with them, that they did wrong, rather than what we did. And I think whatever you think about, you know, Ozempic and other weight loss drugs that are coming out right now, it's going to create a conversation around what is quote unquote your fault and what is disease. And I think if we can leverage that conversation to start moving to, let's talk about diabetes, let's talk about hypertension, let's talk about, I just had a stroke, and say these things are diseases that we can address. I think that's a really interesting place to break down stigma.
I watched a TED Talk several years ago from a doctor who had a total shift of perspective around it's the patient's fault that they are unwell to, oh my gosh, it's so much more than that. And oftentimes it's not the patient's fault, it's the patient doing everything they can and it's still not working for them.
Yeah, not people problems, but systems problems again. I think that's the big message from today. Yeah,
there you go. I also think if we could make it easier within our communities, for instance, to go to a restaurant with a walker or a cane or a wheelchair, so that it doesn't feel like it's this huge, oh my gosh, I'm creating chaos because I need to find a space in the restaurant for my mom's walker, for my mom's wheelchair. I would love for our communities to really think about how do they capture more business by really being friendly to older adults, persons with disabilities, and their family caregivers, because that's a huge untapped market for them as well. Okay, I think we're good. So I think we're going to close for today. I posted in the chat room the link to the evaluation form. You do need to complete that for your CEU, but we'd love anybody who attended to complete it so that we have insights about our events. And Tim, thanks so much for being here. So appreciate all that you offered to us. Thanks for your insights and your expertise.
Thanks, Denise. Appreciate it, everybody.
Yeah, thanks everybody for being here. I hope everybody has a good rest of the afternoon. And thanks so much for sharing all that you did today. Always helps the conversation. Okay, thanks everybody.